In the next section on acid-base physiology, we will walk through the first of the respiratory disorders, respiratory acidosis. Respiratory acidosis is caused by hypoventilation, which results in retention of carbon dioxide. The retention of carbon dioxide can be caused by inhibition of the medullary respiratory center, paralysis of respiratory muscles, airway obstruction, or failure to exchange carbon dioxide between pulmonary capillary blood and alveolar gas. Causes of respiratory acidosis are given in Table 7-6 and Box 7-3, both on page 321 of the text. Table 7-6, the causes of respiratory acidosis, with examples and comments, as outlined on page 321 of the text. The arterial blood profile seen in respiratory acidosis is as follows. The pH is decreased, the bicarbonate level is increased due to compensation, and the primary disorder is an increase in PCO2. The following sequence of events occurs in the generation of respiratory acidosis to produce this blood profile. First, there is retention of carbon dioxide. Hypoventilation causes retention of carbon dioxide and an increase in PCO2. The increased PCO2 is the primary disturbance in respiratory acidosis, and as predicted by the Henderson-Hausbach equation, will cause a decrease in pH. The increased PCO2 by mass action also causes an increased concentration of bicarbonate. The first response is buffering. Buffering of the excess carbon dioxide occurs exclusively in the ICF, specifically in the red blood cells. To utilize these intracellular buffers, carbon dioxide diffuses across the cell membranes. Within the cells, carbon dioxide is converted to hydrogen and bicarbonate, and the hydrogen is buffered by intracellular proteins such as hemoglobin and by organic phosphates. The next step, which would be respiratory compensation, does not occur in this case. There is no respiratory compensation for respiratory acidosis, since respiration is the cause of this disorder. However, there is renal compensation. Renal compensation for respiratory acidosis consists of increased hydrogen excretion as titratable acid and ammonia, and increased synthesis and reabsorption of new bicarbonate. Reabsorption of new bicarbonate increases the bicarbonate concentration even further than the effect of mass action alone. The Henderson-Hausbach equation can be used to understand why the increased bicarbonate concentration is a compensatory response. Recall that the pH is equal to the pK plus the log of the concentration ratio between the bicarbonate and the PCO2. The primary disturbance here is an increased PCO2, and so the compensation is increased bicarbonate concentration to increase pH. In acute respiratory acidosis, renal compensation has not yet occurred, and the pH tends to be quite low. There is an increase in the denominator in the Henderson-Hausbach equation, but little increase in the numerator. On the other hand, in chronic respiratory acidosis, renal compensation is occurring. This increases the bicarbonate concentration and tends to normalize both the ratio of bicarbonate to carbon dioxide and the pH. The difference between acute and chronic respiratory acidosis lies in the renal compensation. Accordingly, based on the absence or presence of renal compensation, the renal rules give different calculations for the expected change in bicarbonate concentration that occurs in acute and chronic respiratory acidosis. Once again, see Table 7-3. Table 7-6 outlines causes of respiratory acidosis. Let's walk through a clinical physiology case of chronic obstructive pulmonary disease. A 68-year-old man has smoked 3 packs of cigarettes per day for 40 years. He has a history of producing morning sputum, cough, and dyspnea, and he has had frequent episodes of asthmatic bronchitis. He is admitted to the hospital with a low-grade fever, dyspnea, and wheezing. His physical examination indicates that he is cyanotic and that he has a barrel-shaped chest. The following blood values are obtained on admission. The arterial blood gas results are pH is 7.29, PCO2 is 70 millimeters of mercury, PO2 is 54 millimeters of mercury, the bicarbonate concentration is 33 milliequivalents per liter. On venous blood, the sodium is normal at 139, and the chloride slightly low at 95 milliequivalents per liter. The man's history of smoking combined with asthma and bronchitis suggests chronic obstructive pulmonary disease. The arterial blood values are consistent with respiratory acidosis, decreased pH, increased PCO2, and increased bicarbonate concentration. When obstructive lung disease is present, alveolar ventilation is inadequate. Thus, his PO2 is markedly depressed at 54 millimeters of mercury. The normal PO2 is approximately 100 millimeters of mercury. This is because there is insufficient oxygen transfer from alveolar gas into pulmonary capillary blood. Likewise, his PCO2 is markedly elevated because there is insufficient transfer of carbon dioxide from pulmonary capillary blood into alveolar gas. The bicarbonate concentration is elevated because of mass action and possibly, in addition, because of renal compensation. The rules of thumb can be used to determine whether renal compensation has taken place, that is, whether this man has acute or chronic respiratory acidosis. Recall that in respiratory acidosis, the change in bicarbonate is predicted for a given change in PCO2. In this man, the PCO2 is 70, which is 30 millimeters of mercury higher than the normal value of 40. His bicarbonate concentration is 33 milliequivalents per liter, which is 9 milliequivalents per liter higher than the normal value of 24. Is this increase in bicarbonate consistent with acute or chronic respiratory acidosis? For a 30 millimeter increase in PCO2, the rules for acute respiratory acidosis predict an increase of bicarbonate of approximately 3. For chronic respiratory acidosis, the rules predict an increase of 12. Thus, the change in the man's bicarbonate is closer to that predicted for compensated chronic respiratory acidosis. He has a history of chronic lung disease. Since the change in bicarbonate is not exactly the value predicted by the rules, a second acid-base disorder may be present. This may be something such as lactic acidosis due to poor tissue oxygenation. To better evaluate this, we can calculate the anion gap. The anion gap is 11 milliequivalents per liter, which is in the normal range, suggesting that if any lactic acidosis is present, it is not yet significant. The anion gap should be carefully monitored for the development of lactic acidosis superimposed on his chronic respiratory acidosis. The man is treated with antibiotics and his lungs are mechanically ventilated. This concludes this section.